this presentation. So please write your questions in the chat box. Linda will be stopping at various points in the presentation to take questions and answer them. And we'll also do that at the end of the presentation. So now I'd like to introduce our speaker. Dr. Linda Morris has a unique experience in critical care, education, research, and rehabilitation nursing. She's an advanced practice nurse with over 40 years of experience. She is a tracheostomy specialist and is the co-editor and author of Tracheostomies, the Complete Guide, with having published the second edition in 2021. She has most recently been the director of nursing research and advanced practice nurse for pulmonary services at Shirley Ryan Ability Lab, and is currently a clinical research scientist. She also holds a faculty appointment with the Departments of Physical Medicine and Rehabilitation and Anesthesiology for the Northwestern University Feinberg School of Medicine in Chicago, Illinois. Dr. Morris is an elected fellow of critical care medicine from the American College of Critical Care Medicine. She has published extensively in the field of critical care and tracheostomies. Her current research interests include tracheostomy outcomes, including quality of life, body image perception, and decannulization of tracheostomy patients. Dr. Morris also provides consultation and expert testimony in medical legal cases involving malpractice and standard of care in nursing and tracheostomy cases. So with that, I would like to turn this over to Linda. And as I mentioned, for anybody who joined after I said this, we will be sending out the slides in a PDF format, and we will also be recording this. So I will send the link to the recording to all of you. So with that, Linda, take over.
Okay, thanks, Cindy, for that nice introduction. You know, and I'm looking at my screen here, and I don't see any chat on my screen. All I see is my slides, so I'm not sure what's going on unless, oh, wait a minute. Oh, there it is. Okay, now I see the toolbar. I had to click OK for the recording. Okay, so let's start.
Join the meeting.
As Cindy mentioned, we have a book, Tracheostomies, the Complete Guide. I personally think it's the best book ever, but I'm not going to give you the hard sell. I'm going to, there's going to be some illustrations that are in the book that I'll refer to. And that's part of the thing. I was insisting with the publisher that we really need to have a lot of illustrations, because most of the problems that occur with tracheostomies occur on the inside, and you can't see what's going on. So hopefully some of the illustrations that I'll show you will help to make it very clear when there's an emergency, what could be happening. I also do some legal consulting. Attorneys call me for my opinion on legal cases, and they call me far too often for trach cases. And so I want to spend today giving you some of the information that you'll need if you have a patient with a trach who goes into emergency. They happen more frequently than you think, so you need to be prepared, and I want to give you the tools to be prepared. So our objectives for today, I want you to be able to identify at least 3 common tracheostomy complications. We'll discuss preventive strategies to prepare for potential tracheostomy emergencies, and we'll talk about the initial management of a patient who does develop a tracheostomy emergency and what you can do in those first few minutes before the paramedics arrive. I have the case I'm working on now, actually, I should mention, and it's from a skilled nursing facility with a trach unit, a vent unit, and the paramedics didn't come for 25 minutes. They were working on this person, unfortunately doing the wrong thing for 25 minutes. So anyway, I want to give you the right things to do so that you can make a difference in these patients. So just about headlines, this tracheostomy catastrophes are multi-million-dollar things. And these are just some of the headlines that I've run into over the years. So let's just start out with some basic stuff. This might be a review, but I just kind of want to make sure that we're all on the same page as far as the terminology that I'm using and some of the data to support some of the care that we provide, just our routine care. So let's first talk about anatomy of a tracheostomy tube. For a tracheostomy tube, sometimes it has an inner cannula, sometimes it doesn't. But when it does, here's the outer cannula connected to, oh, I'm sorry, I clicked that mistakenly there. The neck flange should lie flush against the neck, and this neck flange is connected, in this case, to the outer cannula, and in this case, it does have a cuff. When a tube has a cuff, you should see this inflation line that's connected to a pilot balloon. What this is reflecting what's going on in the cuff. Okay, so then we also have the inner cannula in this case, and the 15 millimeter connector is that universal piece of equipment that connects all respiratory supplies or all respiratory things like the ventilator, the ambu bag, needs a 15 millimeter connector in order to connect it. And then the obturator, its purpose is to help reinsert the tube. And we'll talk about that in a little bit here. Okay. So complications, I'm just going to mention a lot of them right now, and then we'll go into more detail later on in the presentation. So when we think of complications, we usually think of immediate, and that is intraoperative. And I do teach the anesthesia residents on tracheostomy. So we did have an intraoperative fire at Northwestern many years ago, and it was pretty scary. So there's things that can occur in the operating room: fire, air embolism, pneumothorax, hemorrhage. Then there's early complications, and this is usually during the first postoperative week when those tissues are very friable, and if anything happens to that trach and it comes out, for example, those tissues collapse and it's pretty much impossible to get that tube back in. So things that can happen during that period of time are inadvertent decannulation or dislodgement, and I'll talk about the difference between those. Creation of a false passage, pneumopericardium, which is air around the pericardial sac, subcutaneous emphysema, and late complications can happen anytime after the first postoperative week. And that's usually mucus plugs. Mucus plugs can happen anytime. And be aware that most patients do develop mucus plugs. Our role is to help keep them small and the secretions mobile so that we can suction them out or the patient can cough them out. Others, decannulation and dislodgement, again, can happen in the late postoperative period. Tracheomalacia, which is essentially stretching of the tracheostomy, or I'm sorry, the trachea, typically due to overinflation of the cuff. Tracheal stenosis is narrowing of the airway. Tracheoinnominate fistula, tracheoesophageal fistula, tracheocutaneous fistula, and what that is once patients get decannulated, usually it takes some time for that stoma to heal. In fact, we just finished a study on how long it takes that stoma to heal. But after the tube is decannulated, those tissues will usually just heal on their own by secondary intention. But in some cases, they don't heal. And so tracheocutaneous fistula is just an open stoma. It may have closed down a little bit, but it doesn't close all the way. So it affects their voice. It affects their cosmetic appearance. Secretions sometimes are there. And then, of course, you always need to be concerned about infection. Okay? We'll spend more time on some of those later. The type of tube is important, and the type of tube typically changes as patients go from the operating room to get the tube and to the ICU, to maybe step down, to maybe a rehab center, to maybe a long-term care center. And the goals change along the way. So we need to keep up with those goals as time goes on. So initially when patients get a trach, they should always get a cuff trach. But otherwise, after, and the mainly reason they always get a cuff trach is because of the danger of oxygen in the operative field. So after the, then we need to think about, does the patient need to be ventilated, and can they protect their airway? If they don't need ventilation or they don't need airway protection, then we can usually do an uncuffed tube, which is usually a lot better tolerated because we can get patients to talk a lot easier and that kind of thing. Another consideration is does the patient need an inner cannula or not? If they need an inner cannula, it's probably because they have a lot of secretions, a lot of thick secretions. If they don't have much secretions, then maybe we can use a single cannula tube, and we can do a lot of different things with a single cannula tube also. Another consideration is length. Sometimes patients have really long necks. Some people have really thick necks, or maybe they're morbidly obese and they need an extra long tube because they need that extra length in order for that tube to get inside the trachea. They can get inside the stoma here, but there might be a lot of tissue between the stoma and the tracheal lumen. And the fourth consideration is rigid tube versus a flexible tube. The old Shiley tubes used to be really hard plastic. Now they're much more flexible. But some of them are very flexible, like the Bavona tubes are very flexible. They're made of silicone. And then there's really rigid tubes. There's metal tubes, which you may or may not have patients with. So those are a consideration too. So general types of tracheostomy tubes, there's cuff dual cannula, cuff single cannula, uncuffed dual cannula, and uncuffed single cannula. Those are the four general types. And then there's special use tubes, all kinds of different extra length, fenestrated, talking tubes, metal tubes, all kinds of different special types. But we're going to focus on kind of the basic kinds of tubes here. But it's important to know what you're dealing with too. So generally, cuffed dual cannula tubes are for patients who require a cuff tube either for airway protection or they need it for a ventilator. And the inner cannula is there because secretions might be a concern. Keep in mind that the cuff has no role in tube security. The inflated cuff provides the most effective ventilation because if the cuff is inflated, the patient is breathing exclusively through the trach. But if the cuff is deflated, they're breathing mostly through the trach, but some through the mouth and nose. So that's why it provides the most effective ventilation when the cuff is inflated. The inflated cuff helps to protect the airway, but remember, it's not guaranteed. Just because the cuff is inflated doesn't mean that the patient can't aspirate. And also remember, when the cuff is inflated, secretions are going to accumulate above that cuff. So if you need to go on a regular basis, suction above that cuff, take a flexible suction catheter, not the Yankauer, but the flexible suction catheter, and the suction catheter, and stick it way in the back of the throat. Tell them that it will make them gag, but you really need to get that glob of mucus above that cuff. That is a key factor in helping to prevent ventilator-associated pneumonia. And always provide that deep oropharyngeal suctioning prior to any cuff deflation. So cuff single cannula is, again, they need a cuff, but they don't necessarily need an inner cannula. And then uncuffed dual cannula is patient doesn't require a cuff tube. They don't need a ventilator, but they may have it because they need secretions. They have a lot of secretions. An uncuffed single cannula is for the patients that doesn't require a cuff tube, and we're not concerned about secretions. This particular one has the obturator in it, if you're wondering what that is. And then these are different examples of different kinds of special use tubes. This is a Bavona Hyperflex, which is an extra long tube, which is wire reinforced. This is a Traco twist tube, which is a talking trach. What this does is it has a cuff here, you can see the inflation line connected to the cuff here, but it also has this talking port here. There's air port. You connect it to an air source, and it pushes air, through the it pushes air above the cuff here, pushes air up to the vocal cords, and then we have to teach the patient how to speak. Here's an example of a fenestrated tube. You can see there's a hole cut in the shaft of the tube. The idea of that is kind of a good one. You decrease the resistance of the tube by cutting a hole in it, and it forces air. It allows a boost of air up to the vocal cords. The problem is most people don't know that these tubes need to fit perfectly. This fenestration needs to fit perfectly in the airway. And most of the time I've seen people without the proper tube, and then they have complications. This is a silver tube called a Tucker. This doesn't have an inner cannula in it, and this is the obturator that goes with it. But there's all kinds of other ones, which we're not even going to talk about today. I do want to do a little bit of interaction as we're able to. What possible concerns do you notice in this picture? Just take a look, and we'll take a few seconds for you to take a look at it and see what you think. What kinds of potential problems do you see there?
Go ahead and unmute if you want to answer the question.
Or you can do it in the chat too.
Yep. I have the chat open, so I'll see if there's anything that anybody's adding.
Drag or pulling, absolutely. There's a lot of traction pulling down on that tube. Yeah, and that's one thing that you want to try to prevent, because that will start to erode the stoma from the inside. Right, it's not flush with the neck flange is not flush with the neck. That's another problem. That could be a sign of dislodgement. Trach ties are too loose. That's another thing too. Yeah, you want to keep those trach ties very snug with only one finger underneath. I think we were taught 2 fingers underneath, but I just do 1 finger underneath. Yes, it does need tightening. Thank you. And yes, there was a question in the beginning. Is there a handout to go along with? Don't have a handout, but Cindy will be sending you the PowerPoint of this presentation, or a PDF of this presentation. Okay, so let's move on to the next section. And what I'm going to talk about is just tracheostomy care here. What kinds of things do you need to be assessing for your patient? We're going to go over some of the basics of trach care and some of the literature behind that. I'm going to go through it kind of fast because I want to spend more time on what's coming up. But when you're first getting a patient, or you're first evaluating a patient for admission, you haven't admitted them yet. You want to know, when was the tube placed? What type of tube do they have? Why did they get the tube? Is it cuffed or cuffless? Are they on a ventilator? If there's a cuff, is it inflated or deflated? What type of a cuff is it? Is it your standard high pressure, low volume cuff? Or is it like the Bavona TTS, the low pressure, high volume? I'm sorry, high pressure, low volume is the TTS, and the low pressure, high volume is the standard type of tube. You want to take a look at the stoma. When you see the patient, you want to look at the stoma. You want to look at the neck flange. All the information is on the neck flange. You want to pay attention to that. You want to see if that neck flange lies flush against the neck. If it does not, it could be a red flag for tube dislodgement. You want to learn about secretions. What kind of secretions does the patient have? What kind of suctioning requirements do they have? Do they require suctioning every hour or two? Is that too much for your institution? You need to be aware of that. And we've had a lot of times, I work in an acute rehab hospital, and we're looking at patients with trachs all the time. And a lot of times, they approach us when they still have a lot of suctioning requirements. We just have to wait. Okay, tell us when you're down to requiring suctioning every 4 hours, and we can handle that. And you also want to make sure that the patient has all the equipment and supplies that they're going to need for daily care as well as managing an emergency. That's so important that it's always there and that you check it every shift. And I'll give you some tools, and we have a trach checklist that we use, so we make sure that our rooms are supplied with all of the trach supplies that you're going to need. Another thing that we need to be responsible for is ensuring the tube patency. We want to check to make sure that that tube is patent regularly and frequently. And we can do that in several ways. We can, and this is, so we can take a look at the patient and they've got a trach, let's say, but just because the trach is in the neck does not mean that that tip of that tube is in the trachea. So we need to assess where the tip of that tube is and make sure that it's in place. I had one time where, and I couldn't believe this, I was doing rounds on a patient, and I had a patient who was in the hospital. He had had a trach for many years, actually, and he was in the hospital for something else. I can't remember. And I remember that he and I discovered, and I'm not going to go into the whole story, but I discovered that his tube was not patent. His tube, I couldn't get, I couldn't pass the suction catheter. I noticed that the neck flange was not flush with the neck. I don't know if you can see this. The neck flange is here, but it wasn't quite flush with the neck like we saw in that previous slide. I tried to push it back in place and it didn't move. And then I tried to confirm placement by passing a suction catheter. I could only get down a couple of inches and no more. And I'm like, this tube is dislodged. Luckily, he wasn't in any distress, thank God. But it had been that way for quite a while, I found out. And so anyway, so that's why we need to be vigilant about these trachs and ensure that that tube is checked for tube patency frequently. We need to make sure that we provide enough humidity so that the secretions stay thin and mobile. And we want to provide physical mobility, whether that's PT, whether that's just getting them up and walking, a physical, exercise. And I did a study one time using just simple deep breathing and arm exercises. Take a deep breath, hold your arms up as high as you can, hold it for as long as you can, and then down. And I did that on, I don't know, I think about 60 patients. It wasn't an actual, well, we did end up doing a real study on it, but we found that it made a huge difference in patients' ability to improve their vital capacity and get rid of their secretions and then get rid of the tracheostomy tube then too. Suctioning is one of the most important things that we do. And we'll talk about some techniques about that. Keep the stoma clean and dry, keep the inner cannula clean, and be prepared for an emergency at all times, as I said. I did want to make a special note, especially to this group, about turning a patient. I can't tell you how many cases I've reviewed where the trach became dislodged during a turn or a transfer. It's especially a problem with an immature stoma, but it's a problem anytime. In fact, that was the problem in one of the cases that I recently came across. Yeah, in fact, also with the current case that I'm currently working on. Trachs can easily become decannulated or dislodged during a turn. So we always have to assess that trach before and after movement to make sure that that patient is safe, especially before and after. And you also want to pay attention to, trying to hold the patient, try to, make sure those trach ties are secure before you move the patient. You want to assess that during the turn as much as you can, all of those things. So let's talk for a moment about what are acceptable methods to check patency of a trach. Put that in the chat or just unmute and shout it out. Suction, absolutely. Pass a suction catheter. That's an easy way to do it. If we're in an acute care hospital, like with anesthesia residents, for example, they have a CO2 detection device, an easy cap, which is just a real simple thing. But most of us don't have that. In a rehab hospital, in a long-term care hospital, passing a suction catheter is an easy way to do that. Another way is to use the ambu bag and try to ventilate the patient with an ambu bag. If you meet resistance, stop. Do not force air into a trach. But that is another way to check and see if you meet resistance, that's telling you that tube is either obstructed with mucus plug or dislodged.
Another one was stethoscope to the neck.
Stethoscope to the neck. Yes. Yes. If you can hear breath sounds, that will help. Yes. Yeah. But otherwise, yeah, it won't be. Yeah, you can do that. So let's just review. What's the simple, the most obvious purpose of suctioning? Obviously, to remove secretions, right? Yes. What's another purpose of suctioning? What happens when we suction the patient? We make the patient cough, right? So we can stimulate a cough with passing a suction catheter. And finally, as we mentioned, we can also assess patency of the trach with a suction catheter. Inability to pass the suction catheter can mean, as I said, obstruction with a mucus plug or dislodgement in a false passage. Very good. So what I recommend is using deep suction on the first pass, especially on the first pass. I'm a believer in deep suctioning. And, there is some studies to show this, that show the benefit of it. But let me just describe it first. Use deep suctioning on the first pass, and that's basically insert the catheter as quickly and as deeply as you can until you feel gentle resistance, and then withdraw just a teeny bit, and then start to apply suction on the way out. The upper limit is generally recommended to be minus 200 millimeters of mercury, but once in a while you may need to put it up a little bit to get some of those really thick secretions. And we also know we need to allow the patient to recover from each pass of the suction catheter. So they may need ambu breath, maybe not. The patient will usually let you know. And we already mentioned oropharyngeal suction to remove secretions above the cuff. There's not a lot of adult studies about suction depth, and most show no preference of deep versus shallow. But there was one study, which I think is important. They found that no difference on heart rate, blood pressure, saturation, or arrhythmias, and they required deep suctioning because it required less passes of the suction catheter to clear the airway. And I think that's an important thing. I think with suctioning, we have to try to be effective and efficient. And so if we use deep suctioning, we can do both. Now, this is not necessarily for children, but for adults, that's what I recommend. So just a quick video here, just to kind of illustrate this. And this is on a mannequin. And, we've got sterile technique there. We've got somebody to help, which is great. You might not have somebody to help you and try to do it all on our own. We do our best to use sterile techniques so that we don't introduce anything into the airway. But we want to get prepared, get our supplies prepared so that there's nothing more embarrassing than putting a suction catheter down and realize that you've got no suction. You forgot to turn the suction on or something like that. So you want to make sure that you get that all set up and ready to go first. And here she's checking it. She's actually sucking a little bit of that through so you can tell. And then passing the suction catheter quickly and deeply, and obviously on a mannequin, you're not going to be able to get down very far, but you want to get down as far as you are able to. And then, and then suction on the way out. Excellent. Okay. The next thing I wanted to mention is continuous versus intermittent suctioning. And this is continuous is mainly just putting your thumb port on the suction catheter and holding it down, as opposed to, I don't know how you were taught, but I was taught to use the up and down of the thumb for intermittent suctioning. The idea was I was taught that it could damage the tracheal surface. But there really hasn't been any studies to support that. And there is no difference in complications in continuous versus intermittent. Peterson did an integrative review of several different studies and found that they recommended continuous suctioning. So then there's saline lavage. What's the data on saline lavage? This is injecting a small amount, 5 to 10 milliliters of saline into the trach, usually followed by vigorous ambu bagging. They did a systematic review of 17 different studies and looked at all these different outcome things. One study even found there was less ventilator-associated pneumonia with that and less biofilm. They thought it washed out the airway a little bit. 3 studies showed increased sputum volume. 4 studies showed no difference in oxygenation. Overall, it was poor quality of studies, but in general, the conclusion was there was little evidence of benefit, but no evidence of harm. But I got to tell you, I've used it in a few cases when other things haven't worked, and it's a tool you can have in your tool bag. Probably not the first thing you want to use, though. Biofilm. Then there's studies on biofilm. Most studies found biofilm even as early as 7 days after insertion. So you want to be aware of that. So cleaning methods. How do you clean trach tubes? I was taught, and you probably were too, peroxide and saline, or just saline. How frequently? One study recommended 16 times per day. Now, I can't imagine any nurse having time to clean the trach 16 times a day, clean the intercannula. And then one study recommended, no, they didn't clean the intercannula at all. But this was in a study in a CTICU. They didn't clean it for 3 days, which, maybe you can get away with that in a CTICU, but most of the time when you get patients with secretions, it's not going to work. Then there was another study who did brushing with tap water, brushing with glutaraldehyde, brushing with a dishwasher, and then ultrasound too. And then Silva did a study on 5 different cleaning solutions: bleach, chlorhexidine, polydent, peroxide, and saline for control. They found that all treatments were decreased Staph aureus, and all except polydent decreased Pseudomonas. And the surface integrity of the tube was intact with all of the treatments. So it's interesting. Maybe we'll be cleaning tubes with polydent or bleach or something. Then how do we secure the tube? What's the best way to secure the tube? There's really no evidence on it at all. We mostly use the Velcro type ties, but sometimes patients like at home, and they come in, they have chains. I had one lady who had like little pearls here. So the idea is to keep the tube secure. However patients want to do that, that's fine. However we want to do that for patients is okay, as long as it's easy to remove and to put on. Then dressing changes. How often do we change the dressing? Again, there's studies out there. A couple of them recommended twice a day. Another one recommended daily. Other people had other opinions. And then what type of dressing? I think we can kind of answer that. It kind of depends on the patient and what's going on. But these are things that we have always been doing, I think, but we never really had any data to support it. Then there's tube changes. Now, the manufacturers have pretty much always recommended every 29 to 30 days. But what's that based on? Actually, I found out that they do their internal studies, but you probably already know that CMS changed their guidelines in terms of what they'll reimburse for tubes, right? It used to be every month. Now it's every 3 months. So we need to think about cleaning that tube in between for these patients that can't afford, or that won't get a new tube every month. There's a nurse named Gunilla Bjorling who I actually met in Australia, and she did a study looking at the electron microscopic view of tracheostomy tubes after 30 days in situ. And she found changes in almost all of the tubes after only 30 days. So that's a good support of needing a trach tube change every month, right? There was a study in kids looking at trach tube changes every 2 weeks decreased the incidence of granulation tissue. So that's kind of an interesting thing, and this is kids. And they recommended that when sepsis is suspected to change the tube. And that's what we do at our hospital. If the patient has a multi-drug resistant infection, we change the tube in adults every 2 weeks and in kids every week. The best thing to do for keeping the stoma clean, just keeping it clean with saline or soap and water, peroxide for dried secretions, cotton swabs for hard to reach places. The key thing is keep the stoma clean and dry and remove that traction to prevent skin erosion. Want to inspect that inner cannula frequently, as I said. Clean or change that inner cannula as needed. You know what? I'm going to kind of zoom ahead here because I'm aware of the time, so I want to move ahead. We also need to be aware of what kind of a tube that we're using so that we know the proper way to clean that tube. Okay, I was going to stop here anyway for any questions. Let's look in the chat.
I don't see any new ones in the chat, but certainly
Okay.
fill them in on the chat, or you can just unmute and ask your questions. That would be great too.
Okay.
Oh.
So we'll move on, and while we may be getting some questions, let's move on to preventive strategies. How to be prepared for a trach emergency. The first thing is we have created a space in every patient's room for the tracheostomy and other respiratory supplies. We've got it labeled. Every room is the same. And so we want to create a space so that everybody knows where to go to get, for example, the ambu bag or the face mask or the trach cleaning trays or something like that. We want to know where that stuff is so that everybody knows. What we did is we created a comprehensive quality improvement project. And it started with this study from St. Mary's Hospital in London. And what they did is they did some very simple kinds of interventions here, checking the humidity, checking the inner cannula, changing the dressing, checking the safety equipment, checking the cuff, and making sure there was a weaning plan and a care plan documented. And they initially had not great compliance, but then they did a training program, a one-day training program, and as a result of that, with that, what they called a trach bundle of their interventions, they had really pretty impressive outcomes. No trach-related deaths, clinical incidence decreased from 58 to only 7 with no moderate or major events, decreased decannulation time, decreased total trach time, decreased days in the ICU. Some pretty impressive outcomes with just some very simple interventions. So that's kind of what we did is we created a one-page checklist. And for all these tools that I'm going to be showing you, I'm very happy to share them with you, and I'll be sending them to Cindy so that you can use this or you can adapt it for your environment. But this is what we use. We have tracheostomy tube of the same size in the room and a trach tube one size smaller in stock. And that's mainly because of reimbursement things. When I was in an acute care hospital at Northwestern, we had that all in the same room. So, but then when patients left, we had a lot to dispose of. We also keep inner cannulas of the proper size, Velcro tube holders, trach ties, suction catheters, trach cleaning kits, ambu bag and face mask is hugely important for trach emergencies. It should be at the bedside of every tracheostomy patient. And we'll talk about how to use that shortly. Oral care kits, charge portable suction device. And we have these supplies in a bag that's on their wheelchair, and it goes with the patient wherever they go for therapy, where they go for a test. It's always there so that they have the proper equipment with them. The last half of that page is care practices. So we want to check humidification every 2 hours, clean or change the inner cannula every shift, clean the stoma every shift, change the dressing, and one drain sponge, not two, because a lot of times they're packaged as two, and that just pulls the neck flange a little bit further away from the neck, which is not good. Check the safety equipment, check the cuff status, check trach ties for security, check patency of the trach, etc. Functionality, suction system, change the suction, oral care, and toothbrushing. We also need to teach our patients and families how to manage themselves when they go home. Teach them how to check the inner cannula for a clogged tube, how to suction themselves, how to use the ambu bag to maximize a cough. Of course, if they've done those things and they haven't, and they're still not feeling better, then they need to call 911. Also need to teach them how to change the entire tube. And don't forget the Heimlich for tube obstruction. If they've got a big old mucus plug that's way down deep, we can use the Heimlich maneuver to push it up higher into the airway. In fact, there's a group of us, I'm working on this international group called the Global Tracheostomy Collaborative, and there's a group of us who are working with the American Hospital Association to get trach management in the CPR guidelines and how to manage a trach patient. So yeah, here's another resource you might be interested in. This is a tracheostomy tube guide that I created, and have some general comments and general considerations about trach tubes in general for the first couple of pages. And then it has a page for each tube that we carry in the hospital. And it has some features on the top, like what kind of material is it, what is it about this cuff, how to clean it, what sizes are available, where to get it, and then precautions with each tube. And the idea is that you print this page out and stick it in the patient's room so that you and all the staff know how to manage this particular tube, especially if it's one that you're not familiar with. But I'm happy to share what I've put together. There's quite a few different tubes in there. I also created a tracheostomy care at home brochure, if you will, or flyer. It's about 12 pages long or something like that, going into all these different things so that when you teach patients and then you can send them home with how to take care of themselves at home, you've got something to work with here. We created a multidisciplinary team of professionals, trach specialists, allied health, respiratory, medical, and nursing is all involved. Our group is called the Tracheostomy Champions. We're the unit reps for patient safety, provide training, unit-based education. We've also done some research studies and published some articles on some of the studies that we did. Meet monthly, and then I would create a report to follow up. For example, this is an example of a report that I sent to the managers. I found this patient had dark green secretions on the dressing. This patient had the neck flange digging into the neck, redness, no extra trachs, trach ties loose. So then the manager can follow up on these kinds of issues here. So then we would train staff. This is an example of the nurse curriculum that we did. We had module focusing on daily care. Module 2 was emergencies. Module 3 was different kinds of things, types of trachs, downsizing, capping, trach versus laryngectomy. And module 4 was patient and family education. So lots of studies to show the benefits of a multidisciplinary trach team can make a huge difference in length of stay, decrease incidence of respiratory distress or blockage, or increase use of speaking valves. Lots and lots of benefits for a multidisciplinary trach team. And we'll stop there momentarily before we move on to the last section on emergencies, managing emergencies. Question.
Oh, yeah, we have some.
Laryngectomy training? Yes. We do internally. We had an external program that unfortunately they did not renew it for CEUs. So I don't know that it's offered as well, but yeah, I will be mentioning briefly about laryngectomies. Like I've got 2 slides on a laryngectomy, but I wouldn't call it training. But yes, that's important because it's completely different than trachs.
And then do you have training for nursing assistants? Or a training
Yes,
program?
we do have a module on training for nursing assistants, and that's essentially how to help use the ambu bag, how to, or when the nurse is using the ambu bag, how to shower people, how to how to help, those kinds of things. We do have a we do provide a 20-minute training on training the patient care techs is what we call them. But yeah, because they're with the patients, you know. So let's talk about emergencies. So our goal is to prevent emergencies. So the more that we are able to assess, the more that we can prepare. So you want to assess the type, size, trach. We already talked about that. Pay attention to red flags. Do the trach bundle. Keep in mind that the way we treat a patient is going to be different, whether it's an immature stoma or mature stoma. Like I said, usually when the first few days, the first week, all those tissues are very friable. And so if that tube comes out, all those tissues collapse and it's impossible to get the tube back in. So we have to manage a patient with an immature stoma a little differently than a mature stoma. But the first few steps are usually the same. So let's talk about the rarest complication and the most dramatic. The rarest tracheoinnominate fistula is an abnormal connection between the innominate artery and the trachea. It's very rare, less than 1%, but it's very dramatic. It is typically blood is shooting out of the tracheostomy tube. And it might stop all of a sudden, and that's a warning sign. That's called a sentinel hemorrhage. That means beware, because if it happens again, it's going to stay. So you want to get the patient, if you see that, you need to get the patient to the operating room immediately, as the closest operating room that you can get to. The patient needs to go. But if it continues, there's not a lot of things that you can do outside of the operating room, but there are a couple of things. And if you see it, you have to act. If you listen to my voice, remember this. If you see blood shooting out of the tracheostomy, know that, okay, you've got the innominate artery connected to the trachea here, and blood is shooting out. And so shooting up here and out the tube. And so what you need to do then is try to hyperinflate the cuff over here and manipulate the cuff a little bit to see if you can tamponade that bleeding vessel. Don't spend a lot of time doing it, but if it works, great. And then, get the patient, like I said, to the operating room. If that doesn't work, there's one other thing that you can do, and that's even more dramatic, and that is pull the tube out, put your finger in the stoma, and try to clamp that bleeding artery. Meanwhile, it's going to be a bloody mess, so you need to suction, get somebody else to suction. If you put your finger in there, somebody else is going to have to suction and then mask ventilate until the paramedics get there, right? So, hopefully you'll never have to do that, but I'll show you in a minute how to mask ventilate here. Let's talk first about something that happens more frequently is decannulation. Decannulation happens a lot in our place, especially on the TBI unit. Patients are always pulling out their tubes. They could happen because the patient's confused and pulling it out. The tube could be too short for the patient. Maybe it's a morbidly obese patient and they've only got a size 6 Shiley tube. Or there's traction against the tube, like we saw before, or the patient's coughing, or they're agitated, under-sedated, loose trach ties, all kinds of things. Decannulations happen. So we need to be prepared for them and make sure we have extra tubes at the bedside, have a mask and ambu bag there. Decannulated trach is real easy to identify. We have an open stoma. We should have a trach in that stoma, right? And the way that we treat it depends on the maturity of the stoma. If it's less than 1 week, we don't even try to put the tube back in, because it'll probably just collapse and you won't be able to get it in. But if it's a mature stoma, and I'm assuming that most of your tubes or most of your patients are going to have mature stomas, because it's probably they've spent some time in the hospital or whatever before they get to you, right? Kind of like us. So that's probably, but you want to confirm that and make sure. So if you have to put the tube back in, you want to, and I'm not sure if you can, I'm going to stop sharing for a minute so you can see me a little bit better. If you have a tracheostomy tube and you need to put it back in, you need to put the obturator in, because when you put the obturator in, notice that it goes, it covers the tip of the tube. And what the most intuitive thing to do is to put the tube straight down, right? But that's not what you want to do. You need to remember that you have a stoma on the outside that you can see and a stoma on the inside that you can't see. You need to get through both of those stomas, right? So you need to approach that tube as, and let me put it in front here. You need to say you're the patient with the trach. You need to approach a 90-degree. Here's this way. You need to approach the patient with a 90-degree angle, and then when you feel the back of the tracheal wall, you need to angle down toward the feet. So you start out 90 degrees, and then you angle down toward the feet, and then remove the obturator, put the inner cannula back in, secure the tube, and check patency. Okay? Let's share again. Here we go. Okay, so yeah, and then yeah, confirm placement. So 90-degree approach, angle down, secure, and check patency. So let's have a little case study here. Here's a 56-year-old woman who had a trach placed a month ago for failure to wean from mechanical ventilation. The nurse and the patient care tech went into the room to clean the patient and turned her. Immediately, the alarms went off, the ventilator alarms went off, and the patient began to desaturate. So risks during the late postoperative period include which of the following? And there may be more than one. Put it in the chat or shout it out. A and B. A is decannulation, tube dislodgement. Yeah. What about C and D? All of them. Yes, all of them can happen in the late postoperative period. They can happen in the early postoperative period too. We just need to be aware of them. So yes, all these things can happen. So the nurse grabbed the ambu bag and began to bag the patient. However, she met resistance. The respiratory therapist took over bagging and also noted resistance, but continued to bag the patient forcefully. And unfortunately, I've had this happen to myself, as well as to other cases that I've reviewed. So what next? What is or are the most likely causes of resistance in this patient when using the ambu bag? A, mucus plug. A and C, mucus plug and tube dislodgement. C, yes, A and C are actually correct. Tracheocutaneous fistula is an open stoma. It wouldn't cause resistance, and neither would tracheoanominate fistula. Neither one of those would cause resistance, but A and C would cause resistance. So, good, excellent. So the oxygen saturation is now 63%. The nurse identifies that the neck is swollen, one of the eyes is bulging, and there is subcutaneous emphysema along the entire torso. What is now the most likely cause of the problem? D. Yes, tube dislodgement. Very good. Yeah, tracheocutaneous fistula is B. No, that's not going to cause desaturation typically, or neck swelling or eyes bulging. But it's C, tube dislodgement. Because now this is what tube dislodgement looks like from the inside. Okay, you've got a tube that should be going through. Here's the cutaneous stoma on the outside, the one that we can see. Here's the tracheal lumen on the inside that we can't see. That tube should go in this space here, but instead it's in this space here. This is called the false passage. This is the space between the cutaneous stoma and the tracheal lumen. And you need to identify when you're in that space and what happens when you push the ambu bag and meet resistance and push it forcefully. You are pushing air into that space. So you are creating and enlarging what they call the false passage. You're making a bad situation even worse. So you never, ever want to force air into a tracheostomy tube. When you meet resistance, stop immediately and then do mask ventilation. There's one other thing that you can try, but don't continue to try to put the tube back in because people die that way. If you keep doing the same thing over and over again, what you can do is one quick thing, and that is you can do, if you notice that that tube is dislodged, you can keep in mind that that tracheal lumen is not necessarily where you think it might be. So what you need to do is take a look in that stoma, see if you can see that as the patient's making inspiratory efforts, see if you can see that tracheal lumen move into place. If you do, then you can take the tracheostomy tube. Instead of doing a 90-degree approach this way, do an approach toward the head, an approach up here, grab the tracheal lumen, and then angle completely all the way down. That has helped me on several occasions when the airway team called, they couldn't get the tube back in. But don't spend a lot of time. Try it once. If the other people can try too, but what you do need to do is do, let me go back here. Wait. Yeah, these are red flags: neck flange that won't lie flush with the neck, unable to pass the suction catheter, loud voice with an open trach, unable to ventilate, do not force air. Okay. There's one other point, a slide coming up that's coming up in a couple of seconds here. Let's skip over that first. So if you have a patient in respiratory distress with a trach and they're not bleeding all over the place, it's either tube is dislodged or tube is obstructed, typically. And then you need to know, okay, do I have a mature trach? You deal with the left side of the algorithm. Do I have an immature trach? I deal with the right side of the algorithm. Okay, but both of these have the same first two steps. You first check the inner cannula to see if it's clogged up, and you pass a suction catheter. Okay, those first two things. If you're not getting anywhere and the patient continues to desaturate, if it's a mature trach, change the trach. If you can't confirm placement, don't waste time. You can have somebody else, but don't waste time, but go right to mask ventilation, calling the ambulance, and then they'll come and intubate the patient, right? If, however, you have a brand new trach, you start out with those first two steps, but don't even try to change the trach because you're not going to be successful. Just go right to mask ventilation and intubation. Now, what do I mean by that? Here's what I mean. And don't look at the poor quality of this video. This is okay. If you've run into a patient who does not, you can't bag them through the trach. You've tried to bag them through the trach, you meet resistance, and they're in distress, just go right to mask ventilation. And what you're going to find after the first breath or so, you're going to find, they're leaking air around the stoma here. So they're not getting any air. So you need to take that tube out because it's not functional anyway. You need to cover that stoma with gauze, an occlusive dressing. It's not going to be occlusive here. I was doing this too quickly. But you want to cover it with gauze, or even just have somebody hold their hand over it. And then you mask ventilate while you're looking for chest rise here. That is what's going to save the patient until the paramedics get there, okay? So that's why you need an ambu bag and a face mask at every bedside. Okay, 2 slides on laryngectomies. Laryngectomy patients are neck breathers only. So all your efforts have to be directed at the stoma. And a lot of times, this is a patient with a laryngectomy, and that they oftentimes won't even have a tube in place because that stoma will not close. It's a permanent stoma. So they may wear a housing or something, and then this is an HME that they use with a tracheal prosthesis to do esophageal speech, tracheoesophageal speech. So you want to keep a cuffed tube at the bedside, though, so that you can ventilate them if they have an emergency. You can use a pediatric face mask with the ambu bag over the stoma to help ventilate them. Yeah. So yeah, you have to direct all your efforts to the stoma because there is no connection between the upper airway. They don't have an upper airway. Let's put it that way. They don't have an upper airway. Their airway is here. Okay. So the actions until paramedics arrived, you want to know if they have a mature, immature stoma, check the inner cannula for secretions, check tube patency. If the stoma is mature, change the tube. If not successful, call 911 and continue efforts. If there's resistance with the ambu bag, don't force air into the trach. Use the ambu bag with the face mask over the nose and mouth. Cover the stoma to see the chest rise. And you continue that until the paramedics arrive. Meanwhile, you want to check their vital signs. You want to, check all of that other stuff. Contact their physician, etc. But that will save the patient until the paramedics can get there. So I'm only a few minutes late, but just a little summary, an ounce of prevention. We want to keep that stoma clean and dry. Keep the patient well humidified. Check that inner cannula frequently. Check patency of the tube. Make sure you have all the supplies that you need for daily care and to manage in emergencies. And and there's a bunch of resources here. If you want to take a look at them, this is that group I was talking about, globaltrach.org. It's a group of nurses, physicians, therapists, all people who are really passionate about tracheostomy safety. It's free to join for individuals. Hospitals have to pay a fee, but then we collaborate and share data and publish data on tracheostomy outcomes. That's all I have for today. Any questions?
We have one question that I think we should answer before we go.
Okay.
The question is, are we not using stoma masks anymore at any time in a trach dislodge emergency?
Stoma masks. I'm not familiar with that. What is that?
I'm not sure.
Is that like a smaller version of the face mask? You can use that, absolutely. But if your tracheostomy tube is not functional and they have an upper airway, then you can use the upper airway, but can you use a stoma mask makes me think that it's small enough to just be around the stoma.
I think you're right.
Oh, for pediatrics? I see. Okay.
Yeah.
Okay.
Okay. Well, thank you, Linda. Gosh, that was such
Yeah.
a great presentation. I haven't had a good presentation on tracheostomy care in ages. And I haven't, of course, been dealing with trachs for a while, but for anybody dealing with a trach, this was great review and great information. So thank you so much for joining us. And to all of you attendees,
sure.
thank you for coming on and joining with us. I'll be sending out the PDF slides. I'll be sending out the link for the recording and any additional resources that Linda sends me. I will send them all out. Perhaps not until tomorrow, since I will await to see what Linda sends me so I can do it all in one time. But thank you so much, all of you, for coming on. And for our NADONA membership, we will be putting all of this information with Linda's approval, of course, in our resources and toolkits so that it'll be available beyond this presentation. So thank you again and have a great day. Linda, thank you so much. Been a delight.
Thank you for having me. I appreciate it.
Absolutely. Everybody have a great day. And with that, I'll sign off. Great thank yous in the chat box, Linda.
Good.